everybody, welcome back to the channel. My name is Joy. I'm a neonatal nurse practitioner living here in Houston. I make content about nursing, living here in Houston, and how to achieve your goals. If that sounds like something you're interested in, go ahead and push that subscribe button and let's get into the content. Today's video is going to be about the NICU and what a day in the life of a NICU nurse looks like. I'm going to go through everything as far as like when you get to work, what happens, what the day looks like, who's there with you, and how the day is set up. Know someone who wants to be a NICU nurse, please like and subscribe to my channel and share this video with them. I make content about NICU nursing all the time, so this is the place that you want to be if you are interested in being a NICU nurse. So for you guys that don't know, I was a NICU nurse for 6 years and I worked in a level 4 NICU. What I'm about to describe to you may look different if you work in a level 2 or a level 3 NICU. I've also been a travel nurse, and I've travel nursed at a level 4 NICU in North Carolina, and my day was pretty much set up the same exact way. So I'm pretty sure that from hospital to hospital, that's the way the day is set up, and you can expect it to be somewhat similar. And I'm speaking for somebody who's like a NICU nurse for a year. Just so you know, like when you first start out in the NICU, you won't know anything about the NICU. You will have a preceptor, and your preceptor will teach you everything. If you want more information about that and like how the training is, you can watch this video that I have posted. Okay, so when you first get to work, most NICU nurses work 12-hour shifts, and they work 7 to 7 or 8 to 8. I worked 7 to 7, so I would get to work a little bit before 7 o'clock, clock in, and then go into the unit. My unit was pretty big, so it was set up with different areas, and so I would go to my area that I was assigned to. There was usually like an assignment sheet posted in the break room to kind of let you know where you would be for the day, and that was for both NICUs, the one in St. Louis and in North Carolina. It was the same. So you would find your name, look on the assignment sheet, and it would tell you what area that you would be working in for the day. Once you get your assignment, you'll go into the pod or the area that you're working in and find the nurse that has that assignment. So they usually have like an assignment book where the patients are, and then the nurse's name will be wrote on the side of those patients. So then you'll know who the nurse is that has those patients that you're looking for. So you'll go up to that nurse and introduce yourself and just let her know who you are, and then you guys will start report. Some NICUs do report at the bedside, some do it at the nurse's station, so that's just dependent on your unit. I'm used to doing it at the nurse's station. In the NICU, a lot of times we try to keep the noise level down, so talking inside the patient's room can disturb them, and then also if their parents are sleeping at the bedside, that can disturb them as well. You know, it just depends on your unit where you will be working, if you do your shift report at the bedside or at the nurse's station or at your desk. You'll start off with giving sign out, and you'll talk about your patients. In the NICU, you usually have 2 to 4 patients. I'm used to having, 2 to 3 because I'm in a level 4, but say you're in a level 2, you could have 4 patients because those patients have less acuity, so less things wrong. They're more stable. If you have 2 patients, each baby will have a schedule. I'm going to talk from perspective of having 2 to 3 patients, what the day will look like with 2 to 3 patients. So each baby will have a schedule. You will have at 8 o'clock, at 8:30, 9 o'clock, or at 8 o'clock, 9 o'clock, 9:30 baby. These are stable babies, and so their touch times is every 3 hours. We refer to the time where we go in to touch the baby to do our assessment as touch time or care time, depending on where you work. In St. Louis, for me, it was care time, and then now here in Houston is touch time. So that just depends on where you work, the language that you use. You'll do your 8 o'clock baby first, obviously, and then your 9 o'clock baby, and you try to stay on time with their schedule. If you have a baby that's 8:30 and you run into their schedule, that kind of puts that baby behind. So that's the reason why time management is very important in the NICU. Once you sit down with the night shift nurse, you'll begin to get sign out, and she'll talk about the patient's background, the history, when the baby was born, how old the baby is, what happened during delivery if it's a new baby, all the things that are important important for you to know during your shift. Then she will go over like how much the baby eats, anything assessment wise that you need to know, any medications that the baby has, any social issues, and then you guys will go over the orders together and look and make sure that everything that she's telling you is what is ordered. You'll go in and take a look at the baby together, make sure everything is right. And if the baby has any fluids hanging, you'll take a look at the fluids, make sure that the rates are running at the rates they're supposed to run at. And then that's shift report. Shift report is over and that night shift nurse will leave. So now those patients are your patients. Once you take report, you are responsible for those patients. So, okay, say it's 8 o'clock. I will first go into the patient's room, make sure I have all the supplies that I need. If I don't have all the supplies I need, there's a supply room that's somewhere close by. So you can just go in there and take a look at all the supplies. It usually has everything that you need in there. And then you'll come out, take all your stuff in there. One thing you want to do is make sure you're clustering your care. So you don't want to start touching the baby, realize that you need a syringe or realize you need diapers and then have to leave the room, go back out into the supply room. Like, you don't want to do that. Once you get into bed and start touching the baby, you want to have everything that you need. So that's why it's important to walk in there and assess the environment. Make sure you have everything that you need before you get started. Then what I always do is wipe down my baby's bed space with disinfectant wipes. I'm going to wipe down everything that's a high touch area that people usually touch with their hands. So doorknobs, the refrigerator, if the patient has a refrigerator in the room, the dresser knobs. I'm going to wipe everything down that people touch. Anything that somebody touch needs to get wiped down. The buttons on the monitor, like whatever you can think of, light switches, all those things need to get wiped down. Yes, housekeeping does do that, but it's always best if you, the nurse, make sure that you wipe down that area for your shift, because you want to cut down on as many germs as possible, at least for your shift. So after I'm done doing that, I will go into the baby's bed. So say this baby is a small baby and they're in an isolate. I will go into the isolate and put my hands on the baby, just lay my hands on the baby. Something I always tell people, like when I'm precepting, is think about like if somebody came into your room in the middle of the night, snatched the covers off, turned the light on, and stuffed a bottle in your face. You know, like you would not like that. And so I try to treat the babies the same way that I would want to be treated. So I go in, I lay my hands on the baby, you know, might whisper good morning, you know, something soft, something low, and just give them time to realize that you're there before you start messing with them. After that, I'm going to do an assessment by first starting to look at the baby, look at the skin, look at the way they're breathing, look at anything that looks abnormal or normal, just whatever, just do an assessment just by looking. And then the next thing I'm going to do is listen to the baby. I'm going to listen to the lungs, listen to the heart, listen to the belly. And then after that, you can start to do your other things, which is feel the belly, look at the skin, move them around, get your blood pressure, those things that you need to do. But first you want to start by looking and listening before you actually disturb the baby and wake them up and have them crying and be upset. Heart rate is high. Now your blood pressure is high. So you just want to do all those things. And keep in mind, like with our babies, we want to move as fast as possible, but you need to be as thorough as possible. So get in and get out, but make sure that you're taking the time to actually look and see what's going on with the baby. Your vitals, you're going to get your blood pressure, your temperature, things like that. Then you can change the baby's diaper. You know, you might need to change the outfit depending on if they have clothes on or not. If they're in isolate, 9 times out of 10 they won't have clothes on unless their humidity is off and you know they're getting close to coming out of the isolate. But if they're in a crib, they'll have clothes on, so you might want to change their clothes, get them dressed for the day, comb their hair, you know, whatever. Just get your baby presentable for the day. Then after that, you're going to start their feeds. So if they're getting formula, then you know you can just pour the formula in the bottle if they're taking a bottle, or in the syringe if they're going to be taking their formula in a syringe. And if they're getting breast milk, you're going to need to warm that up. So if your baby is getting breast milk, what I like to do is start warming my breast milk up before I even start touching the baby. That way when I'm finished with my care, cares, the breast milk is done being warmed, and it's ready for the baby. Okay, so now you've done all that and you fed the baby, and now it's time for you to go out and chart. So you're gonna go out and chart your assessment and what happened during your first set of cares, and then you'll be ready for your 8:30 baby. So then you'll go in and do the same thing for your 8:30 baby, and then it'll be time for you to do your 9 o'clock baby, and that's exactly what you will do. You'll do your 9 o'clock baby the same exact way. You'll chart all of your assessments and everything, give your meds if you need to give your meds, and then it'll be around 10 o'clock. So around 10 o'clock is usually when the medical team comes to round. It's a multidisciplinary medical team. So you'll have your respiratory therapist, your dietitian, pharmacist, attending, nurse practitioner, resident. Everybody will be there, and the nurses can either participate in rounds, which is called nurse-led rounds, where the nurse kind of goes over the baby's plan of care for the day, or they just listen in. So it depends on your unit and how it's set up. I've worked in both type of places where the nurse lead the rounds, and then also where the nurses just are in the rounds and they're actively listening. If it's nurse-led rounds, the nurse will go over the assessment and the plan of care that she got in report, and then the medical team will talk about what the plan is for the day. So if they're going to adjust any type of medications, or if they're going to, get a eye exam, or if they're going to change their respiratory support, or if they're going to change the feedings, whatever it is that they plan on doing for the day, that's what the medical team talks about. And then everybody understands what the plan is. Then you'll go on to your next baby and present your next baby to the team. This is the time where you ask the medical team any questions you have if you don't understand why you're doing something. So like, for instance, if you have this medication that you don't understand, number one, you always want to make sure you look your meds up. So if you come into work and there's something that you don't know, like, yes, you know about vitamin D, but you might not know what caffeine is for. So you will look that up before you even give it, because it's important as a nurse to know what the drug does before you give it. If for some reason you have more questions, this is your time where you can ask the medical team, like, hey, why is this baby on caffeine? Or can we stop the caffeine, or whatever your concerns are. This is the time for you to voice those concerns. Okay, so after rounds, it'll be around 11 o'clock, which will be time for you to do your baby again, because the baby's schedule is 8, 11, 2, and 5, or 9, 12, 3, and 6. So you'll do your baby again, you'll do your 8 o'clock baby again, and then your 8:30 baby, and then your 9 o'clock baby. So 11 and 12 o'clock you'll be doing your cares. You'll do the same exact thing. You'll go into the room, you'll do an assessment, you'll get the vitals again, you'll listen to the baby, change the diaper, all the same things, and you'll chart what you did. And you'll do that for your 8 o'clock, and you'll do that for your 9 o'clock. So if you do it for 11 and then 12, now it's 1 o'clock. So 1 o'clock is lunchtime. That's usually when you can go and take your lunch. And then sometimes it don't really work out like that, because everybody can't take their lunch at 1 o'clock, but that's usually the time where we start to get the lunches in. And then, your charge nurse will set it up so that everybody has a chance to go and have lunch. This is also another time where you have time to call parents, let them know what's going on. Or if you have parents in the room, you can go in and talk to them, just give them an update. If they missed rounds and they don't really know what's going on, you can talk to them about that or educate them. One of my favorite things I like to do with parents is like teach them how to give a bath or teach them how to feed their baby. Parents are so happy when they get a chance to participate in the cares. So this is a time where you could do that, walk them through scenarios, and okay, so if your baby is doing this, this is how I would set them up. If your baby needs to burp, this is how you burp them. Things like that. Parents really enjoy that time. Walking through the unit, you'll see all the babies in their isolates and all the babies in the cribs. You'll see other nurses and charge nurses and respiratory therapists and dietitians. You'll see everybody in the NICU, in the unit. So know your resources. If you ever need help, know who you can reach out to. There's always a senior nurse around who has the knowledge that you're looking for. You can always ask the medical team about things, and then your charge nurse is like your main person. That's your like big resource person, because if you don't know who to ask, then she usually knows who to ask. So as you're walking around the unit, you'll see all of these things. So lunch is over and you come back around 2 o'clock and it's time for you to do your cares again. So you'll go in and do the same exact thing. You'll assess the baby and get the vital signs, change the diaper, feed the baby, and then chart it. And you'll do that for all 3 of your kids from 2 o'clock to 3 o'clock, because it'll be your 3 o'clock baby, and then you'll be done. So you'll go ahead and chart your 3 o'clock baby, and then you'll have that 4 o'clock downtime where you can do what you need to do as far as like talking to parents, calling parents, or sitting in the room just kind of going over, you know, the things that I said before, how to feed the baby, how to change the diaper, those things. Nurses are educators first, and so we educate parents a lot throughout the day. We are also very supportive emotionally. So we sit in there with the parents and we hear them, we hear their concerns, and we explain to them things that they don't understand. Usually when the doctor comes in and talks about, you know, what the plan is and, you know, what's going on with their baby, when the doctor leaves, they usually have questions for the nurse. They want you to explain more. They want to talk to you about what they just heard. So 4 o'clock is a good time to do that, because you usually don't have a baby due at that time. At 5 o'clock, you'll have your last set of cares. So you'll go in and do your first baby. And then you'll have 6 o'clock cares. So between 5:30, and 6 o'clock, you'll be doing your cares again. After that, your shift is almost over. So now you have to make sure you get all your charting done, and you're ready for the night shift to come. So you have her room set up, make sure it's nice and clean, make sure it's organized, because you never want to leave a nurse with a disorganized room and, you know, without supplies. Try to make sure that you treat nurses the same way you want to be treated. So yeah, you'll get ready for that. Shift change will come around 7 o'clock. Something I want to say, the way this shift is set up is based off of a very stable baby. Okay, like these are stable babies. They're not very sick. If you come in and you have one patient, that means that patient is pretty sick and needs you. So that baby might be on an oscillator, a ventilator, getting surgery, anything like that. So your day will look a lot different depending on how stable that patient is. If you have a very small baby, you won't touch the baby every 3 hours. The goal is to touch the baby less. So it'll be a minimal stim baby, which means you'll probably do it at 10, 2, and 6, or maybe just 10 and 4, depending on how stable that baby is. So your day will look a lot different if you have unstable babies versus stable babies. You can also have a procedure that day, which the baby can have a bedside procedure, like if they have surgery at the bedside, something like that. And then you could also have to travel. We call it travel, where you have to take the baby to MRI, for example. So you would have to pack the baby up and take them there. If that was the case, you wouldn't have 3 and 4 babies, because you wouldn't have the time to do all the cares for all the babies like that. But those are also things that can get thrown into your day. The way I explain the day in the life of a NICU nurse is solely based off of having stable kids who don't need to leave the floor and who don't need procedures and who, you know, are stable respiratory wise. Let me know below if you have any more comments about the NICU, and don't forget to like and subscribe if you are interested in NICU content. Share this video with your friends who want to be NICU nurses, and I will see you guys next week. Bye. Baby,